All right, and I believe we are live. Welcome, everybody. Thanks as always for checking us out on Note to File Live. Kind of switching it up this week a little bit. In the past, our guests have been sort of coming off of a podcast appearance. I have done a podcast with Dr. Grew here, but has not come out yet. So since we're doing a little bit different, I'm going to mix it up, and I'm actually going to have Dr. Grew kind of introduce himself and tell us a little bit about him. So, David, please.
Sure. Yeah. So, Brad, happy to join you live. This is fun. And I'll give a quick kind of overview. I'm a physician. I practice radiation oncology in Hartford, Connecticut at a Yale affiliate cancer center. But I also just have kind of a longstanding interest in patient education. So, even as a medical student, I was really interested in using visuals, simple visuals to help kind of deepen my understanding of scientific, medical, physiologic, biochemical pathways and so forth. So when I was studying in college, I would always be drawing things out on paper, on whiteboards to kind of better understand it. Kind of carried that all the way through medical school. I taught the MCAT to undergrads while I was a med student to earn extra money. And I would always do whiteboard presentations for that. And then as an oncologist, it's just part of my practice is to get out either just, the paper on the exam table and draw up some diagrams so my patients understand, where their cancer is and what other organs are in the area and what kind of treatments we're going to offer them. And then when patients started asking me to kind of rip off the exam table paper so they could take it home and show their family, I had this idea to convert a lot of this pen and paper live explanation into a digital asset that could be shared at scale. So about 2 years ago, almost 2 years ago, I started building a library of digital short educational videos for patients with cancer, about 50 of the most common explanations I would give my patients with cancer, and built a web platform to distribute to them at scale by email or text message. And was just getting a lot of positive feedback from my patients. And then got into the clinical trial space much more recently because some of my friends who are PIs on trials saw what I was doing. Like, this would really help me. I have to explain my trial over and over. It's hard to do that in the constraints of clinic. And so could you start building content to explain this complex trial with visuals so that we could standardize and scale our education? So that was about 8 months ago, and it's really taken off. It seems to be adding a lot of value for PIs and for sites. So that kind of brings us up to now. I'll stop there.
Yeah, no, I think this is awesome. I mean, a big problem or issue, within the clinical trial space is, awareness and education. I mean, it's a as somebody who goes through the consent process with patients on a regular basis, I know that it's it can be challenging to, first sort of determine a baseline level of knowledge a patient may or may not have, even about the condition that they have, right? Because everything kind of builds off of that in the first place. So not just from a even a clinical trial aspect, but from a, understanding of their own health condition aspect, it can be challenging. And a lot of coordinators aren't necessarily, clinicians or maybe even have strong clinical backgrounds, right? So I think it's really cool to have, that sort of tool to be able to, provide that level of understanding, because it still happens to me all the time. I mean, I've been doing this, I've been working on certain therapeutic areas for a long time, but questions come up that I'm like, I don't know. I got to figure out, I got to go talk to go talk to the doctor or the medical monitor or somebody like that. So I love the idea of being able to create at least a, baseline level of understanding of the condition, but then, getting specific into clinical trials, because that's its own mess, right? Like it's a lot to say, okay, well, now that you understand what this condition is, here's why this clinical trial is happening, here's what's involved, here's the hypothesis we're working off of, or whatever the case may be. There's so many, it occurs to me how much we expect from patients to know without giving them those resources, right? And I feel like that's continually a problem.
Absolutely. I think a key challenge for people who are kind of boots on the ground for clinical trial recruitment and enrollment is you have to get patients. It takes quite a bit of time to just get them up to speed on what's the current standard of care, what's the treatment for them. And then for trial enrollment, you need to go above and beyond that, obviously, to explain why, even with the standard of care, there are still a lot of unanswered, very key questions. And so that's how we kind of structure and build our content. We educate for about the first third of the content piece about the current standard of care, the disease state in general, and what the considerations are for just general the problem with unfavorable intermediate risk prostate cancer. What is that? How is it treated now? What's the current standard of care? The middle third, or kind of act two, is what is the key question that this trial is asking? And then the final act is what is the treatment on the trial? If it's a randomization, and then what's entailed in sort of the ongoing follow-up testing and all that kind of stuff. So I think that's just been an effective way to give like the arc of the story for patients who are eligible participants. This is my problem. I can relate to this. I've heard this from my doctors. And then here's an unanswered question that I've actually wondered about probably myself, but maybe I haven't heard it quite in that way with the visuals and everything. Try and get that to click. And then here's what entails. So if someone gets through that piece of, we deliver that in 2 minutes. And if they can get through that and they're interested, then for trial sites, for PIs, you're basically now dealing with a patient who's engaged and motivated. They sort of cleared that hurdle of standard of care and cleared the hurdle of understanding like the basic parameters of the trial. And now the people who go through those gates and are still interested are pretty motivated.
Yeah, and again, I love that concept because again, it's to your point, it's as they say, informed consent's a process, and there it is. And it starts with a lot of times with that education. So the better they can come in, understanding their disease state and clinical trials themselves. The quicker you can get into the nitty gritty, so to speak. So I want to run one of the videos. I'm going to bear with me, guys out there, because I haven't done this yet on a live stream. And also, if you're on LinkedIn or YouTube, I want to encourage you to, post your comments and questions here. We do these LinkedIn lives so we can get some sort of community engagement. But I'm going to try this out. So bear with me. If I screw it up, I mean, it won't be the first thing I've screwed up, but here we go. I'm going to give it a shot here. And I guess you can set this up. I believe this is a prostatectomy trial.
This may be, if the prostatectomy one, it may just be general education on standard of care for more just like general clinic use. But go ahead. Why don't you run it? And
yeah, we're going to give it a shot. Here we go. I'm going to try to get the audio included in here. So here we go.
Weill Cornell is leading a randomized phase 2 trial of salvage radiation therapy for prostate cancer in 4 weeks versus 5 days. The purpose of this trial is to compare the side effects of longer and shorter courses of radiation. This is a side view of the male body. The prostate, shown in green, is a small gland located deep in the male pelvis. If we zoom in, you can see the prostate lies just in front of the sacrum, or the tailbone. Just behind the prostate is the rectum, a tube-like organ where stool leaves the body. Above the prostate is the urinary bladder, where urine collects. Urine leaves the bladder through the urethra, a tube that dives through the prostate and leaves the body through the penis. When men undergo prostatectomy, the entire prostate gland is removed, and the bladder is pulled down deeper into the pelvis and sewn back together with the remaining urethra. At the time of initial diagnosis, men typically have an elevated PSA, which leads to a biopsy. If they choose to undergo prostatectomy, PSA is expected to go back down to 0. Over time, we'd like to see the PSA stay at 0. However, in some men, the PSA begins to rise. This PSA elevation could be an indication that prostate cancer cells are trying to grow back, right where the prostate gland was removed. In this situation, adding radiation can be a curative treatment. Radiation is given to the entire area where the prostate gland was removed. Typically, this is done with small doses of radiation every day over several weeks, up to 4 to 8 weeks total. A new treatment called MRI-guided radiation therapy allows doctors to precisely locate the other organs in the area, like the bladder and rectum. In the image on the left, the rectum is empty and the bladder is full. In the image on the right, we can see that the rectum is actually filled with gas now, pushing the target forward. With MRI guidance, we can account for this and make a more accurate treatment. With this, they can limit the dose to these organs and dramatically increase the dose to the target every day. Because the target is getting a much higher dose per day, they can shorten the overall number of days required for curative treatment. In this trial, doctors use real-time MRI guidance to deliver treatment in 4 weeks versus just 5 days. Neither the patient nor the doctor gets to decide whether they receive 4 weeks or 5 days of treatment. 4 weeks of treatment is currently considered a standard of care treatment option. 5 days of treatment is a new treatment option, currently being studied on this trial with real-time MRI guidance. Even though the number of days of radiation patients receive on this trial is different, the overall dose and effect of radiation is designed to be equivalent in both groups. Men are eligible to enroll on this trial if they've had a prostatectomy in the past and they now have an elevated PSA with no evidence of distant metastatic disease. Patients on this trial will be required to undergo MRI-guided radiation, imaging testing, laboratory testing, and periodic questionnaires to ask questions about urinary and bowel habits. If the trial shows that 5 days and 4 weeks are equivalent, the men who are diagnosed with prostate cancer recurrence in the future may benefit by added convenience, lower costs, and overall reduced burden of cancer treatments. Men with certain conditions will not be allowed to participate for safety reasons, including prior radiation, inflammatory bowel disease, or second cancer, as well as a history of urethral stricture. If you would like to learn more about this trial or enroll, please contact us at the email listed here, the phone number, or scan the QR code.
Yeah, so I can give a little background on that trial too. So
Sure.
that's a trial that's it's industry sponsored, and they're obviously looking to accrue rapidly, but also educate patients about the technology that they have available. So their technology is really cool, allows, as you can see from the video, real-time MRI guidance allows us to kind of shorten treatments in ways that we couldn't before. So for patients who are maybe traveling from out of state or traveling long distances, typically radiation is given over many, many weeks. And in some cases, that inconvenience is actually a deterrent to even participating in standard of care treatment. So this trial is using that technology to test shortening treatment just to basically 5 days of treatment instead of the current standard over many weeks. It's complex. I mean, it involves a lot of tech. So a main sort of mission of mine is to not have patients decline enrollment on a trial simply because they don't understand it. And so that's sort of like a core value of mine, that patients should if they decide that they don't want to enroll on trial, they should do that after having completely understood the trial. But we can't be losing patients just because it's complicated. So we're trying to use simple visuals. You know, the kind of the aesthetic that I'm pulling from is what I was describing at the top. We're just kind of like drawing on the exam table paper. So keep it simple, black and white, simple, like primary colors. Doesn't need to be more complicated than that, in my opinion.
Yeah, and again, I mean, if you're we do a lot of, outreach to patients and patient engagement, trying to, find people who are interested or qualify for our clinical trials that we do. I mean, unfortunately, almost all studies, really, aside from just having a conversation, the only sort of tool we have is sending somebody a consent form. And oftentimes, I mean, without exaggeration, those are 49-page documents in some cases. And to your point, you don't want to scare off a potential patient because they either don't understand or become overwhelmed by the level of information that's being thrown at them, or they feel like they're signing away some kind of contract. And instead, this is a great entry point to be like, look, here's a way to understand not just what the study is about, but maybe how it directly relates to your disease state. Again, I think it's an amazing idea, and frankly, surprised we haven't seen this utilized more across the clinical trial space.
Thanks. No, I mean, it because the classic startup story of like solving your own problem. So this really came about because during early days of COVID, I had a lot of elderly patients coming in when we had a no visitor policy who, they couldn't bring someone to help them, take notes and understand things. And so it was quite clear that these poor folks, like, they have a new diagnosis of cancer, they're meeting by themselves with an oncologist, and it just was wrong. And so that was a big part of what prompted me to start creating the digital assets to explain these things. And it just accelerated from there once I started to learn more about the pain points of folks who work in the clinical trial space. It seems that, if the pain is here for, clinic standard of care, and then for clinical trial sites and PIs, it's that much higher because you have to do both. So that's kind of how things got rolling. And it does seem obvious now, but I don't understand why people haven't done that more in the past. Maybe you have more insight than me.
I mean, yeah, it's hard to say. I mean, I can't tell you how many times I can just remember this specific example because it happened a lot, but I'd be talking or approaching patients who have heart failure. And so, we'd walk in, I'd be like, okay, well, we're doing a study for heart failure. Well, I don't have heart failure. What's heart failure? I don't have that. And I'd be like, oh shit. Now I got to try to explain, and I'm not a doctor. I'm not a clinician. I shouldn't necessarily be the one explaining to them, what heart failure is and how that affects them. But I've seen that sort of thing happen over and over again from a trial site perspective. But I don't know why, frankly. I think, actually, I don't know. I can't even begin to think of a good reason. And unfortunately, clinical trials are full of things like that, where there's a lot of intuitive and simple solutions that we just simply haven't, utilized or implemented more wisely. So I guess, tell me, you're spinning this off, or this has spun off into sort of its own business at this point. Yeah.
It has, yeah. So the company is called PRIMR, PRIMR, and the idea is, the same way we use it in clinic. It's to introduce a concept, give patients a short primer before you have a longer live discussion. We obviously, our mission isn't to replace the doctors with video robots and code and algorithms and stuff. It's just to give patients a chance at like a first pass, like 30,000 foot view of what's going on. So we are looking for partners at this stage. So we have mostly partnered so far with individual PIs, but we've also have early partnerships with trial sponsors. And we have a partnership with one site, it's big. Columbia University has a pilot going on right now in the breast cancer patient education space. Kind of just exploring the space generally, and welcome outreach from folks on any side of the clinical trial space. Like I said, we're kind of working with all parties. So I'm learning a lot. I know the medicine well. I'm getting better at the content. We're building an awesome content team, but I need to learn more, to be perfectly honest with you, about the day-to-day functions of sites, because I understand you guys are the ones who are doing most of the work of getting these patients, educated and then onto the trial. So I can build the content, but as far as the tech, the delivery mechanism, is I'm slowly building that to make sure that it works within. I'm a fan of your pod, so I understand there's a bit of a morass of different applications that you're using to enroll patients on trials and collect data, send it off to PIs and sponsors and everything. So I don't want to add to that, right? I want to be helpful. I want to make things run better for you. I want to be leveraging content in a way that's not adding work for you guys. So I can only do that if I have partners who are willing to, use the content, but help me understand about how we need to build the tech infrastructure around it, whether it's just going to be APIs that that plug into your operating set, your CTMS.
Mm-hmm.
Yeah. So whether it's that or some other way, just using like text delivery to patients that you've identified, or partnering with clinical trial like enrollment platforms or patient recruitment platforms that are serving you with patients who are candidates, perhaps plugging in via API so that once you identify those patients, they get served kind of very curated and custom content for trials that they're eligible for, and then allowing them to kind of click through and present themselves to you guys for enrollment. So I'm open to ideas, open to partnerships for anyone who's interested.
Yeah, I mean, it's interesting, and I give you a lot of credit for being thoughtful about the delivery, because it's a really good point. I mean, it's you know, in the spirit of keeping it simple and making everyone's lives easier, you don't necessarily recreate the wheel with yet another platform that, you know, people have to deal with. And even as a site, it's a good question. I mean, for us, we do a lot of communication through our like CTMS, which does have, you know, the ability to text information out to patients. But then, you know, does the site host it? Is it like a locked YouTube channel somewhere where you can kind of control who sees it and who doesn't, or not? Is it just hosted on, you know, those are on Vimeo, I think. So that is an interesting question, and I would have to think there'd be some interest from the CRO sponsor side, because you can create some consistent messaging, because, you know, for better or worse, sites are kind of like their own animals, right? Like, you don't know, every site runs differently. Every site has a different level of customer service, let's say even education, or, you know, the way that they interact with their patients. So in some ways you can at least standardize what patients are learning up front, rather than leave it up to the sort of variation that, you know, maybe somebody who answers phones trying to explain trials to people that they don't even have a very good understanding. So again, I can really appreciate how that could just kind of keep that a consistent experience across the board. But I'm interested, of course, from a site perspective, you know, like, you know, sometimes lots of money gets dumped into advertising that doesn't really go anywhere or do anything for anybody. You know, you've got bad stock images that, you know, get thrown up on Facebook or whatever the case may be. But being able to utilize, you know, our study budgets to, you know, work with you and create content that's specific for the site, but, you know, obviously gets IRB approved. I mean, is that a model that you've been approached by yet? And if not, then again, I might want to talk to you more.
I'd be delighted to. That is sort of the model with like the very earliest adopters. That is the working model. So you have like a core piece of content that's unique to the trial, but then, you know, we can apply logos and sort of customize it to the site. So this trial that we just watched the content for is started at Cornell, but they, I think, just opened at UCLA. So this piece of content is kind of in review at UCLA, and they have international sites they'd like to enroll on. So yes, like once you have a trial, we create one core piece of content. It can be scaled across different sites. So yeah, I mean, like I said, I'm still learning quite a bit. So I'm open to all kinds of, you know, innovative ideas, partnerships. And as it relates to the issue you're bringing up around what we're up against. So like what's the current standard? And I've talked to a bunch of PIs who are saying, well, you know, I have no insight into the level of education or the quality of education across all of the enrolling sites. And oftentimes the educational materials are delivered as PDFs or as physical paper. So you're obviously not getting any insight into the level of engagement among patients who are just, you know, receive those things. One thing that's been extremely interesting since we set up the platform to deliver this content is we just learned so much about how patients engage with it. Like, for instance, we can see if a patient opens it, views it, but then we can see how many times it's viewed. So we can see if patients actually watched it and then shared it among their family members. And then we also attach when we're creating content for trials, we distribute to the customer embed code, so they can use that across all social platforms and on their native websites, wherever they want. And then we collect monthly analytics. So we're pulling the data of all the engagement across all those platforms, and then we deliver it back to the PRIMR customer so that they can see like where they're getting traction. And oftentimes it's just not where you would necessarily think. I won't go into the details, but like there are a lot of like just really interesting surprises. And so it's kind of goes back to that thing, like that which can be measured can be managed. Historically, we had no insight into that, the patient education. So a lot of budgets got dumped into creating these PDFs and distributing that, whatever. And it's a lot of time. It's very manual, but you're getting nothing out of it in terms of insights into patient engagement. This is just a different way of doing it. It's dynamic. We're getting live data back across multiple channels, so you can kind of see in real time. And if you're a site, you can see, right, well, Facebook is really hitting, but in maybe in these zip codes, not at all. And it's actually Instagram. And maybe why would it be Instagram when we're targeting 75-year-old patients? Well, maybe it's their kids,
right?
Like TikTok, whatever it is. And you can just be much more strategic about how you target people based on levels of engagement.
Yeah, and that's a really fair point. And historically, as you mentioned, we wait around and we get a FedEx package that's got 60 patient brochures in them. We'll go distribute them amongst some clinics, and we'll check in on them every now and then, but really no idea who's taken them, who's thrown them in the trash, who's passed them on to so-and-so. And, you will find, throughout the process, someone will say, because we will ask, how'd you find out about the trial? Oh, my grandma's friend knows so-and-so, and they handed me this brochure. And I'm like, huh, that's cool, but there's no way to like manage that at scale. It just happens randomly. So yeah, to have that level of insight, because you learn a lot like through those, just to your point, like maybe sometimes it's not the people with the problem, maybe it's the caregiver, right? That tends to be the person engaging, or someone else, in the, grand scheme of things. So I find that really fascinating, and something that maybe sites don't always fully appreciate. But being able to give them that knowledge is a, huge. And we do have a question, which I think is, a fair question. Is content reviewed and approved by an IRB?
Sure. Thanks, Joyce, for the question. It is always. So anything for a trial that's going to be patient facing is always reviewed by IRB. And we've been lucky that we're still batting 1,000 on that. So we have the scripts approved generally first. Sometimes some IRBs will allow us to submit both the script and the video at the same time. But with bigger IRBs, we worked on some NIH funded studies where it goes to central IRB. And we've had no trouble yet. We haven't had any, haven't even had any notes come back. So everything that we've sent in has come back totally approved. But yes, everything has to be approved before it sees patient eyes. I'm excited because just before we logged into this, we got approval for a video for a very large, like an international trial that some of the bigger IRBs, any IRB can take time, but this one was a big deal. And so we can start distributing that content, and that's awesome because it's a very complex trial with 2 randomizations based on a gene score. So, hard, as you said, Brad, you send folks, if you send them a consent packet that's 40 plus pages and has 2 randomizations based on a gene score, it's complex stuff. It's not intuitive for patients. So, if we can use this kind of simple content to just like introduce the concept and then have the longer conversation after, I think it helps.
Yeah, no, I agree. And I just happen to have, this is sitting in my office. This is a lot of the kind of stuff that gets handed out. It's a small book talking about the trial, and it's cool, it's great, it's useful, but it's, again, you don't know where these end up, or where they go, or who's following up with them, and again, it's certainly not as engaging as look, let's not kid ourselves. TikTok, Instagram, short, digestible pieces of content, are king, right? I think there's a
Better
lot
worse,
to be
that's where we're
said for
going
that.
as a society,
Right. Oh, let me ask you this too. Just out of interest, speaking of sort of the IRB side, and we all know anything patient facing is going to get IRB approval. What about developing, things just for the sort of healthcare provider side that doesn't face patients? So if, like, I'm trying to drum up referrals, and I just want to get information out to all the physicians, like, is that something you guys have looked at or done, or maybe would just be easier since it doesn't necessarily require IRB approval?
The IRB approval, even though it can be lengthy at times, hasn't been a terrible hurdle. We have, although you did key on an insight that was not expected by me, but a key motivator for PIs is drumming up less. They're more concerned with drumming up information, enthusiasm, and amplifying the trial to other doctors, which makes sense because they need to enroll patients at scale. So some of my partners have come to me hoping that using the content would do what you're describing, getting excitement going among potentially like referring physicians or other enrolling physicians. At its core, it's meant to be patient education, but because it's 2 minutes and it's fairly high level, and sometimes referring providers are not clinical researchers, I think, some of these trials are so complex, even a board certified physician needs a 2-minute primer video
For sure.
to understand
For
it,
sure.
because it's complex stuff.
Another question here from Michael. What's up, Michael? Can PRIMR collaborate with SMI as they share very similar missions and objectives? I'm not sure who SMI is. Maybe you are, David. If not, Michael, can you elaborate on SMI?
I'm not familiar either.
Yeah, I can imagine you're not necessarily the only one, who's thought of this. But again, it's still just so crazily underutilized, again, in a way that is kind of shocking to me. I'm trying to think. At this point, I've been 15 years at the site level. I've worked on hundreds and hundreds of trials, and I can only think of a couple instances where there was some sort of video, component or content like this. And frankly, it was so long and so boring that I hated that part of the screening visits where I'd have to show the patients these videos, because it was, immediately they were like, yeah, okay, yeah, I'm watching it, sure. It was just not necessarily a good experience. And there's something else I was curious about. Do you see any potential for things like dynamic consent? So having, like, as e-consent sort of becomes more popular, being able to embed a series of videos within a consent form, and sort of, I feel like that would be a really cool potential there, where you can touch on, maybe again, like disease state, clinical trial specific. Maybe there's like a primer on, your rights and responsibilities as a clinical trial subject. I feel like there's a big can of worms there potentially.
Yeah, we've thought about that a lot. We haven't made specific content for the consent process yet, but I know e-consent is, if it's not already, it's becoming a standard of care, sort of SOP, I guess. So I think there's a ton of room there. We do need to be sort of mindful about like eliminating the human element altogether.
Sure.
So I don't know. How do you think about that as it relates to full adoption of e-consent, and how do you think about that?
Yeah, that's a good question, and I'll be really honest. I feel like the again, e-consent's been fairly underutilized in the trials we've worked on. And there's even been, to your point, maybe some resistance sometimes from me and our team to sort of fully eliminate. There's something to be said about a patient showing up, having a conversation with them in person, because also every trial we work on is, I mean, it relies on that patient coming to see you every so often, right? So sort of like getting them in the door the first time is a real good, sort of a test to know, like, okay, are they going to be committed to actually participating in a trial? And that's kind of a sad way to look at it in a way, but at the same time, there's nothing worse than, if you consent somebody and then they don't never show up for a visit, you really haven't done much. You haven't done much good, right? It's cool, you've delivered some information to them and they've agreed in concept, but you're not going to collect any data. So it's a good point. I think there's a balance to be found. And I think, of course, immediately for me, the idea of maybe, having that initial conversation remotely and being like, look, I can send you a video and take a look. It's 2 minutes. It'll tell you what you want to know about the study. I'm going to follow up with another phone call and we can get you scheduled. Being able to work that into your pattern, but not necessarily, to your point, you don't want to replace. You don't want to be like, here's the consent form with a bunch of videos. Good luck. Tell me when you're done. You don't want to do that.
Exactly. And that became quite clear from doing this in my own clinical practice. As an oncologist, was completely uncomfortable replacing, the conversation about, a new diagnosis of cancer and the treatments and everything. But it can be an enormous help. And where I've seen the most leverage is when I've actually taken the time to call patients ahead. Hey, Mrs. Jones, we're going to meet tomorrow to discuss for an hour your new cancer diagnosis. But right now I'm going to send you a video by text message. You can watch it at your leisure. And there's a lot of stuff in there that we're going to address tomorrow. So that tends to be an extremely effective way. I get the very best feedback I get from patients is when I introduce the concept of digital education content in that setting. Where it works less well is they arrive at clinic and they're served with content immediately, or they get the content after we've already had a full discussion, because, it really is, it's short, it's not the whole thing. And so, if you give it to them after you've had the full conversation, it's like, yeah, he just said this kind of thing. But with a personal outreach and then with the content served ahead of a larger conversation, it seems to really resonate with patients in that setting.
Yeah, I mean, that makes perfect sense to me. Another great question here. Thank you, Erica. Amazing work from David. Have you seen or able to measure yet any sort of, ROI in terms of the content at this point, or is it still early on in the process?
Thanks, Erica. So it's fairly early on in the process, but for the one sponsor that's been really supportive of the content, we're able to report back to them. The main ROI is hours watched by patients of content served by a healthcare provider. And I don't have data on, as that relates to like the number of consents signed and this and that, but we're kind of tracking that on an ongoing basis, but we're still early enough in the game that it'll take some time to get good data on that. But in the first 2 months, I think we had 18 hours of content watched by patients of 2 to 3 minute videos.
I was going to say it's pretty good in short
Pretty
2-minute
good,
snips.
yeah, with just a few sites running. So I do think that really the sponsors saw the value in that, because it's not advertisements, like they're not spraying this wide. This is incredibly targeted to patients who are already searching for this kind of thing. And you're basically giving them a highly curated piece of information that's totally relevant to them. So they're very engaged. That's why you see them coming back and watching it again and sharing it, and their family members are watching it. This is the thing that they've been talking about around the dinner table, for the last several weeks. And now they've got this piece of content that's specifically about that. So I think that's why the engagement is enormous once they get served with the content. The trick is pairing them up. The trick is figuring out how to match the eligible patient with the trial and then serving it to them in a way that they will engage with the content. So we started with email. We tested SMS, got much higher rates of engagement. That's intuitive, right? Just pops up.
Right.
We're in clinic, just pops up in front. You just click that, and then the video comes up. So there's no login for them. It's just like a single click and the video plays. And so the engagement is extraordinary when we serve it to them in that setting.
Yeah, I'd be really curious, and maybe it's something we can talk about offline, because we do a lot of advertising and we do a lot of interacting with patients. I'd love to be able to put some like conversion rates, or like see what sort of increased conversion we may have as a result of delivering good, concise education. Because man, you can get on these phone calls with patients and you can be talking for 45 minutes and still not really get anywhere. So in terms of patient, really educating the patient on the trial. And, that, especially if you're a trial site specifically, that's challenging, because, clinical trial sites or standalone companies, tend to be, every dollar counts, every minute counts. We don't get paid for, educating patients. Unfortunately, we only get paid if those convert to enrollments. So I'd be really interested to see, how that could potentially help increase conversion, or I don't know, maybe cut down on some of the sort of, again, it's tricky balance, right? You don't want to take away the human element, because there's a lot in that's sort of a relationship building in those conversations. But I guess being able to just supplement that with some more clear and concise patient education data. I don't know. I like that.
Yeah. I think that's right. I think I think a key element of it is like getting the immediate feedback around engagement and around different platforms and stuff. And so you can be a lot smarter about the placement of the content. But we've talked about using or sort of A/B testing a kind of a randomization of delivering content versus standard education at like a massive scale. But to do that, the trial size that I was discussing that with, it really should be, they wanted it to be part of the protocol, that there was a second randomization. There was it was a medical treatment randomization, and then they wanted to add, they thought, an education randomization to see if, you could measure this signal. But that is a lot of work. That's a lot of extra work. There's got to be a lot of extra budget. And this trial was kind of like already out of the barn. So we all decided that was just too big a bite at the first try. This was their first time using this kind of content. So we decided to just like, everybody will get it. But then, at a smaller scale, like at the site level, I think you do have discretion about how you distribute content. So I think it would be perfectly ethical to, try, I'm sure you'd A/B test advertising all the time. You could try whatever the booklet that you showed me versus a piece of digital content, and just see what's working better for you. I think that would be very reasonable. That's obviously less powerful data, smaller numbers, but you would get a sense very quickly, I think. When I started using this in the context of just like my oncology clinic, you don't need to do it for very long to see. The signals are generally pretty strong.
Yeah, no, that makes perfect sense. And another great question from Joyce. At this point, had any interest or collaboration with patient advocate groups, since this would seem to fit right in with their missions?
We have. So we've mostly worked with the large trial that we just created content for is through the Alliance for Oncology, and it's a metastatic bladder cancer trial, and they work with. I have to pull up the email. I don't want to say it wrong, but it's BAC, bladder cancer. I think it's BCAN, Bladder Cancer Advocacy Network. So they have a pretty robust listing on their website for patients to search for trial eligibility. And they were willing to put our content on there to help just further educate the patients. They have the whole write-up, which is mostly, I think, pulled from clinicaltrials.gov. So I find that to be not very lay. So I think this adds to the value of their resource that they're delivering for patients, because it pairs the general sort of, it is, I think, meant to be lay, but it kind of is overwhelming for patients, the clinicaltrials.gov information. So embedding this short video on top of that, I think, is extremely useful for them. So we're very early partnerships, but the answer is yes, a little bit. We'd like to explore that quite a bit more, because I think they're extremely powerful distribution networks for patient education.
Yeah, and I wonder, again, just thinking out loud here, but like, more like sort of public health type initiatives, like colorectal cancer screening, or things like that, where if you could deliver some, I mean, I know there's some studies going on now, even that whether patients who have certain education delivered to them are more likely to go get a colonoscopy versus those that aren't. You know what I mean? I feel like there's probably some big, I mean, not just opportunities for the education, but obviously opportunities for increasing, public health in general. I mean, I feel like there's probably, you have some really interesting possibilities here. It sounds like.
Yeah. We're the pilot that we're doing with Columbia is along those lines. It's not screening, but it's for women who've had breast cancer surgery and are at risk for developing lymphedema. We're testing the standard of care delivery of lymphedema education and screening versus delivering it via a series of videos. So, Brad, you mentioned earlier, when you've used videos that have been long and you kind of lose patients. I know you do, because we have over 1 million impressions now on our content, and we can see when patients stop watching it. And for the longer stuff, it just tanks at a certain point. So we've learned to transition from longer form content to serving bite-sized content at key points in the patient's journey throughout introduction of the trial enrollment, and then during the actual conduct of the trial and the administration of the medicine to the follow-up phase. So I think testing on a trial, like whether it's screening or prevention of a side effect or complication from treatment, with testing education in a controlled way, is going to answer some of these key questions that we all have around, like, what is the best way to do this? By training, I'm an oncologist. I've written protocols. I would like these things to be tested in a controlled environment. Sometimes we can't, but I think we can design studies to get a better sense of, what is going to work better for patients.
Well, and I know we touched on this. I'm going to hit one more question before we head out. I know we touched a little bit on delivery and systems or platforms. Is there what are you seeing now? And again, we talked about SMS being probably, if I had to guess, that would be a great and easy delivery system. But as you scale up, I mean, which way are you leaning, I guess?
So as I said, we're kind of, we have a platform that delivers the content to patients by text, but we have heard feedback from sites that logging into yet another platform is onerous and difficult. So we let our partners decide how they want to serve it to patients. At some sites, they've taken the content and plugged it into their own native websites so that they just direct all patients back to their own website, and the content is housed there. And they kind of like that, I think, because they get the SEO from that. And they're basically getting patient eyeballs back to their own site. And so using the content as a way to drive more traffic to their sites is attractive to them. But we do have a proprietary platform that we give our customers access to as well, that basically just delivers it as a simple text message. And we also have analytics built into that. So patients can, or our users can see in fairly granular detail, like when links were opened, how many times they were viewed, the % of the video that was viewed, whether or not it was shared, these kinds of things. So
Yeah.
as you're using the platform, over time, you start to pull out the trends in terms of engagement and things like that. The other option is to basically just aggressively post on social. So that's what I see pretty much every day. I put different kinds of videos up there because first of all, we've created it. We want to share it, but we also want to learn about who is interested in this stuff, so we can find partners and come up with better ideas and basically make the product better.
Sure. Yeah. No. And again, there's again seems like a lot of room for opportunity. I love the idea of putting on an eCOA device. Unfortunately, I mean, you kind of already have to be in the study, or in order to even have that device. But if you're doing anything ongoing, like ongoing education or ongoing engagement, being able to push it out straight through a device the patient already has as part of the study is kind of an interesting option there. But I know we're getting long on time here. Where can people find you online?
Sure. So right here on LinkedIn. There's a long list, but I'm pretty active on LinkedIn, pretty active on Twitter, and the handle is at Dr. Grew. Our landing page for the product is PRIMRmed.com. So it's PRIMRMED.com. And you can email me at just my name. So it's David Grew at PRIMRmed.com. I also have a YouTube channel. That's where I kind of started doing the stuff for my own patients. That's more clinical stuff, clinical patient education, less the trial stuff, but that's Dr. Grew Explains Cancer on YouTube.
Nice. Very cool. Well, Dr. Grew, man, I appreciate you coming on. Any parting words before we sign off here?
And Brad, I'd just say thanks again. I love what you're doing. I can't tell you how much I'm learning from the content that you're creating. And I just on a personal level, I hope we can find ways to collaborate and work together down the road. I think there's a lot of potential synergies between PRIMR and clinical trial sites.
Yep, I agree 100%. All right, guys, thanks for tuning in, and we'll be back next week.